Hello.
Everybody. I'm very happy to be here and to give you a talk about a complex bifurcation. It is, we will put into practice what Thierry said just before with this live case. We did this case 2 years ago for the Euro PCR. So I have no conflict of interest with that. So it was for a male, 72 years old, with a diabetic patient with hypertension, and his lifestyle was he was independent. For clinical history, had no previous cardiac history and renal impairment, and he came in our institution for angina class 2. For the biology, he had only an increase of the creatinine with low clearance of creatinine, 35 milliliters per minute. And he had a previous echography showing the fact that the left ventricular function was well. And he had also a CT scan showing a very tight stenosis of the LAD just at the ostium, and another lesion a little bit far away from the ostium. And you see here on these output views on the CT scan that the lesion was not really very calcified, but very tight and very ostial lesion, including a little bit the left main, but just a little bit without any very tight lesion. Here on the angio, we can clearly see that we have an ostial lesion of the LAD without any disease of the left main. Regarding the angio, we have also a stenosis between 60 or 70% of the first marginal branch. On the other view, we can clearly see that we have also another stenosis at the middle part of the LAD and a very pathological diagonal branch, which is a long branch coming from the part who is diseased at the proximal part of the LAD. Regarding the right coronary artery, which is a dominant coronary artery, there is no significant stenosis on this coronary artery. So the logistic Euro score was less than 2%, and the Syntax score was 18. And for the Syntax 2, we have for the mortality at 4 years, a little bit more than 13% for PCI, and a little bit more than 10% for CABG. So to summarize this case of a male 72 years old with chest pain, angina, as cardiovascular risk factors, he had diabetic patient with hypertension, good left ventricular function, and a disease of the left main, which is 010, and a tight stenosis of the middle part of the LAD, 80%, the diagonal 70%, and 60% for the first and the second branch, marginal branch.
Okay, let's stop here, Hakim. We'll take the opinion of the panelists first, how to tackle the strategy. Okay, let's start by Dr. Said Farag. How are you going to manage, and how this is a trifurcating or bifurcating lesion, and what's your opinion? Are you going to do 2 stents the diagonal?
So the strategy was to stent. We will use the intracoronary imaging to define clearly the strategy for this case. But you will see that the strategy will be to do an angioplasty of the ostium of the LAD with the stenting of the left main and stenting the LAD at the middle part, and doing pots of at each level, and opening all the struts regarding the diagonal branch and regarding the circumflex.
Okay, let's take the opinion of the panelist first. How are you going to manage?
If you look at the picture, the main bulk of the stenosis is not involving the ostium of circumflex and also not involving the ostium of the diagonal branch.
Yeah.
So the strategy is to fix left main and LAD and to open the struts and to take a decision after that.
But you have the diagonal also 70%
in the mid part.
in the
not ostial.
Yeah. No, it's not ostial. It's a proximal lesion.
Yes.
So you're going to stent this diagonal till
after I put a stent to see if the ostium is.
But you know
affected.
that it's more simple to put the stent to fix the diagonal with stenting before. It's more simpler.
Yes, I know that.
But you're going to do it after.
Yes.
Okay, Dr.
You
Saeed.
can do it before and you can do it after.
I think again here the imaging has a great role, especially we are in the distal left main, because even angiographically, if we can see some plaque distribution, but I think in managing the it is not only important for the procedure but also for the outcome. We have to assess the distribution of the plaque very well, the size of the LCX and LAD and left main, because by doing so we will assess properly the technique we will go through.
Dr. Noumani, what's your
Actually, I agree with Professor Satiha. I will fix the LD and left main at first to save the patient the left ventricle, and I will try for the diagonal. Even it is maybe more difficult as a second step, but I will fix the LD and distal left main at first.
And my co-chairman, Dr. Khalid Shokri.
I'm not sure that the plaque involving distal left main. So I prefer to dilate and do an IVAS before starting to take a decision to involve or to intervene left main with the LAD or only the ostium of only starting with the ostium of the LAD to the distal part.
Okay, Dr. Subhi, without the IVAS, are you going to fix the diagonal or just do the stent from the left main to the mid LAD and ignore the diagonal?
And another opinion. Do you have something, Hakim, in the obtuse marginal, OM? You said that there is a lesion in the OM. Can you show us?
60%.
Because if you have a lesion in OM, I will start with the OM first and fix it, and then go for wiring diagonal and the LAD and to left main, and then fix the diagonal, and then I will take one stent from the LAD to the left main, and then pot and recross and kissing. Because I have to finish with the OM if I'm going, because I will not keep park the stent only in the ostium LAD. But because I think this is something, without an IVAS, there is a lesion in this plaque distribution in the left main. So first of all, to check for the OM. Second, stent the diagonal. Third, to make one stent LAD left main, pot, recrossing, kissing.
Okay.
Amazing strategy, Muhammad. What we did for this case is, first of all, we did a FFR of the marginal branches. And the FFR was not significant hemodynamically. So we treated the LAD with the stenting of the left main and the LAD with a long stent, and as a provisional stenting for the circumflex and the diagonal branch. And we did a kissing technique for both bifurcations. So let me show you now the images from the intracoronary images with OFDI.
The result was from 82. So we didn't do any angioplasty of both arteries. And the strategy, we have done also, of course, the OFDI to define our strategy for the procedure. So it was the main question: should we avoid the left main or put the stent from the ostium of the LAD up to the bifurcation with the diagonal, or should we cover both the diagonal and the left main? So this is the full bag. maybe we can do it again. So pull back from the LAD distal to the bifurcation with the diagonal. You see there is a lot of disease. Now we are at the level of the lesion, which is very tight. Then we have the bifurcation here, okay, and now we have the proximal part of the LAD, and then can we go slowly at the level of the bifurcation. Yeah. So now we are at the ostium of the left man, as you can see. The size is relatively large, so 296. Can you go back? Yeah. Okay, so pull back very slowly. You see there is a lot of plaque, some calcium. Okay, so this is the bifurcation with the third, and you can see that, can you go back a little bit more, that there is a lot of plaque at this level. And now when we are proximal, can you go back? Proximal, yeah, proximal. Okay, so bifurcation with the third, and now the distal left man, and you see a lot of plaque at this level. So we think that it's not reasonable to try to avoid.
Is it possible to ask a question, Professor? Can we ask a question?
Cover the left man using only one stent.
Yes. Dr. Hakim, why you use an OCT and this patient has a renal impairment? Then IVUS was more safe for this patient to avoid much contrast?
On 3.4 millimeter. So we use a Swiss pipe that we deploy at low pressure because it's very important for the scaffold to be able to expand at the size of the left man, which is 5 millimeter, as you saw with at the OFDI. So to prepare this complex.
Okay, we can discuss what we have as information with intracoronary imaging, if you want.
My question, Dr. Hakim,
Please.
You select an OCT, and the OCT needs a lot of contrast, and your patient has a renal impairment. Why you didn't use an IVUS in this case?
Yes, it's a good point. We did only one OCT for this case because of this renal insufficiency, of course. But for this live case, we wanted to be very educational for this decision and the strategy making. So with the images of OCT, it was really more precise to make a measurement and to see everything from the left main to the VLAD. Regarding the extension of the lesion and regarding all the diameter, of course you can do that also with IVUS, but in our practice we prefer intracoronary imaging as OFDI. But it's a very good point.
So the strategy now, any comment after having the data, the imaging? So the policy will be the same now. So it's crossover.
I think from the OCT, the black is not including the distal. See the OCT, the image of the OCT, that it is limited to the ostium of the LAD. The black is limited to the ostium of the LAD.
Yeah, but you can't put the stent and adjust it to the ostium. You will cross over, of course.
No, by Zabo technique, you can adjust only one strut in the left main. It will be sufficient for this lesion.
So Dr. Khaled Chokri is suggesting to spot stenting rather than crossover.
Can I?
Dr. Stehas.
Yes, Zabo technique is a beautiful technique, but the circumference is not that big vessel. So if you do one or two struts protruding in the circumference, it will affect the flow. So crossover is more safe in this case.
What about the size? Because there is a huge discrepancy in the size.
Yes, you can have, then usually you can put the stent in the mid part first, and you cover it with select Sera or Onyx, 3.5 or 4. You can open up with 5.5 the left main. So it's new generation of stenting can manage this.
Manage this problem.
Yes,
So
yes.
so most of the panelists will go for crossover.
Yes.
Only one opinion here is with spot stenting. So let us see what you did, Hakim.
Okay, so let's go on the.
Here we have wired the DLAD, of course, the diagonal branch and the circumflex, because the strategy was covered the left main. And we did the pre-dilatation preparation here, the OFDI. We did the preparation of the LAD with a non-compliant balloon with the high pressure 2.75 balloon to prepare the LAD. And we have right now the stent 48, length, 25 in diameter, 35 in diameter. So we have to practice I think that we are covering the middle part of the LAD. We have to check the ostium, of course. So it's not necessary to go up to the ostium because there is no technique. But of course, we need some space to be able to post-dilate proximally. So maybe we can do an angio at that time, check where we are exactly. Yeah, I think so.
The WASAM will be seeing the stent deployed any moment now, but are you comfortable with the strategy based on the imaging and the extra physiological information?
Yes, I think I agree with the single stent that you original center. I think that may be the plan that you can as it is a bifurcation, and maybe we end up with a single laser.
Right, it gives you more options potentially. Okay, Thierry, we see the stent being deployed there. Did it deploy easily? Did it expand well in the lab?
Well, personally, but not well distally, but it's 3.5 and the vessel is 3 distally. So we just make a long inflation, and after fitting the bifurcation with the LED, we'll post-dilate with the 3 high pressure. So the next step, so it's a provisional approach again. So the next step for long balloons and long stent, we have to control the guiding catheter with the left hand here. We do not perform any compression of the stent and do it very gently. The next procedure, we have wired the DLAD, of course. We are going to do a stent test to be sure that we are inside the stent. Okay, that's perfect. Perfect position. So we have
Maybe we can discuss some points that we showed right now. First of all, the preparation of the lesion with a non-compliant balloon. Another point which was interesting was the opportunity to use the 7 French catheter when you do bifurcation like this. What is your opinion in the panel?
So we'll start by the second one. Would you use routinely, Dr. Syed, 7 French or 6 French in such a lesion, trifurcating?
I think some of the manufacturer for the 6 French give us the ability to use it, but not all the manufacturers of 6 French regard the inner lumen. So far, I'm not sure what is available in the cath lab. I'd like to choose the 7 French from the start to make more space for doing such a complex lesions.
So you are with 7 French?
Yes,
Dr.
7 French.
Dr. Muhammad Sadiha?
Yeah, I am with both.
No,
If-
choose.
In this case,
Yes.
6 French you can manage because
Okay.
the ostia or both ostia, small caliber and
You're doing it with 6 French,
Yes.
like myself. Okay,
Yes.
Dr. Nomani?
I prefer 7th French.
7
Gives
from
more
the
space
start.
for facilitation, manipulations.
Okay, and
I prefer 7 French.
7. Dr. Sobhi.
So we have 50% 7 as 50% 6.
Hakim, if you have more than 2 wires, I like 7 French. If we have 2 wires, and in my mind, I'm going to do 1 stent, and the big vessels are big, so I go for 6 French. So depending on the anatomy and what you are going to do, not generally, 6 French can be beneficial, as my colleague said that according to the manufacturer, not all 6 French catheters and not all balloons can adopt 2 balloons, depending on the manufacturer balloon itself. Because some balloons cannot be used 2 balloons in 6 French diameter. So yeah, and also according to the technique, if you are going to do, for example, crush or decay crush, I don't like to do 6 French.
Dr. Magid, yes.
Okay.
I just have a comment that he didn't cover the whole the left main. So my opinion is that he should cover all the left main because it's more easy later on to do the pot than you limited the left area of the left main. Okay, but my opinion is if I'm doing it, I have to cover all the left main, not to leave it this. And even if I put an next distal stent.
Even he did an OCT, and the proximal left main is almost normal. Eh?
Yeah, that's a very good point, and it's very interesting to discuss that because it is a very good point. The left main at the ostium was not diseased. That's why we decided to do not put the stent on the ostium. But usually, when we have a diffuse left main disease, we of course cover also the ostium. The second point which we have to keep in mind is when you have the ostium covered with a stent, you have to keep in mind that the longitudinal compression can be a problem for the treating the left main regarding the bifurcation, distal bifurcation, because you have 2 balloons, you have in this case 3 wires. So if you can leave the ostium of the left main without any stent to be compressed, it is better for us.
But in this case, as Dr. Magid mentioned, there is a short left main, so the distance for both will be insufficient.
It is a very good point. What is the good, when you have no disease of the ostium of the left main, what is the good distance between the proximal part of the stent and the bifurcation? It is the length of your shorter balloon in your cath lab. If you have 8 millimeter balloon or 6 millimeter balloon or 10 millimeter balloon, you must have a landing zone of on the left main, which is this length. So for this case, we had 8 millimeter or 10 millimeter of landing zone in the left main to do our pot in a good conditions.
Yeah, Dr. Said.
Dr. Hakim, my question is, I totally agree with the 1 stent strategy you did from left main to LAD. But what is your objections about using 2 stents, one fitting the distal diameter and another one overlapped fitting the proximal diameter in the left main? Do you think you have an objections for this? I totally agree with what you did, but the objections about that.
Sometimes when you have overlapping in stents, we know that it is more thrombotic, but it is not completely sure. So you can do it also using 2 stents with different diameters. For this case, the length of our stent was sufficient to cover all the diseased area. So that was only for this reason that we put only 1 stent.
Okay. So I think we had this point clear, and for preparation, non-compliant versus compliant, I think both are okay as long as there is no calcification. Any other opinion?
There was semi-compliant, except this kind. I never do it with the non-compliant. Just semi-compliant balloon, for preparations. For kissing, for example, it's not mandatory to do as two non-compliant. Maybe a side branch semi-compliant and the main vessel is full. This is for kissing. But for preparation, semi-compliant, except if you have a calcifications for the vessel which cannot be used only for semi-compliant.
Any further comment? Dr.
Yeah, most of the time I use an NEC balloon for preparing the lesion.
NC, you prefer
Yes,
NC?
yes,
Okay.
yes, yes.
Okay. So I think
The last point is usefulness of the stent V's to make a good pot to cover the proximal part of the bifurcation without any protruding of the balloon and making a geographical miss.
What size of the stent?
3.5.
The size of the stent was 2.5.
And the size of the left main on OCT, it was how much?
Was 5.
3.5. This is an Science Prime or Science
Science.
I think Sarah is only Science can go for 5 or 5.5.
Yeah.
And the 3.5 from Science Prime, I don't think it will reach 5. It's very difficult to reach 5. So Science, the normal Science. The Science Sarah can go up.
This one was able to reach 5. You will see that.
Okay. Let's
move.
Yeah.
Nice expansion of the stent proximally. Of course, we'll have to do so I will close like that. And then we'll use so this is the street five again. So we can go to very high pressure now. And we'll use the 5-4 to do a cut in the left hand. So 5-0, 8 millimeter. 8 millimeter. Okay, so 20 atmosphere. So you see on the stent, again, we know the stent is already. Yeah. So you see on stent that the stent is well deployed. Of course, it's too small for the left man, but it's well deployed proximal to the bifurcation with the LED and diagonal. And distally it's not open, but by purpose, because you don't want to go to high pressure in this vessel, which is 0, but the stent is 3.5. So of course, after the pot, we'll go with the third wire to open the first one, the diagonal, the big diagonal, and the and we will decide what to do for this diagonal. Yeah.
The Hakim Thierry, I think that Javier has got some useful insights on the case thus far to present to the main arena. So we'll let you work for a few moments. And Javier,
okay, perfect.
Please share some information with us.
Thank you very much, Bernard. So I think that for the time being, what we see is a very nice illustration on how the colleagues have been using intracoronary imaging to make decisions. As you can see, they went to the vessel with OCT, LED, and they assess a number of aspects. On one hand, they could see very nicely the structure of the vessel. For example, in this location here, we could see how they could find the spotty calcifications that actually in this case we already knew that they were there because they had moved this nicely. So it was nice to see that actually in this patient at the level of the left main had virtually no calcification whatsoever. Second aspect is that they could also identify areas that would be adequate for landing the stents. For example, in this distal part that you can see here, you can see that there is much more circumferential plaque, for example, than the place that they have choose for landing. I'm just taking this as an example. They are making just the measurements also for the subsequent treatment of the vessel. And finally, one of the most relevant aspects any time that you treat a left main is understanding the mismatch in vessel diameter that we have between the left main and the landing zone. It's going to be very important. We have found that there is a good landing zone which has a diameter of about 3 millimeters in terms of luminal area. Remember that we can still have room here to go from external elastic lamina to external elastic lamina, so they can go easily, perhaps to 3.5 without any problem, you know. But they have to select stent design, stent type that has a possibility to expand in a 3 millimeter or 3.5 millimeter configuration can be expanded later to 4.72 millimeters in the left leg. Otherwise, they will have a problem of proper position of the stent. And the other aspect that we were just seeing now in the last part is how nicely they were using stent enhancement angiography to make decisions as to where to perform port. So as you can see, they have beautifully identified the edge of the stent, and that's where they are performing. Remember that it was mentioned before that when you make port, you have to position always your, be careful not to display the carina or bifurcation. So this beautiful illustration of how to use these techniques in real life. That's very, very instructive. Let's go back to the cath lab now. Hakim, what steps have you taken while we've been listening to Javier?
So we did the proximal optimization technique with the 5-port oil balloon. Yeah. In the left lane. And now we control. The result seems to be good in terms of stent positioning and proximal optimization of the stent. And also the result on the diagonal trench, the part was it looks nice. Okay. Maybe, yes. Maybe we have to focus to the LAD because when we expanded the stent was not very well expanded at the middle part of the LAD, so we have to do it right now. But we can press the diagonal and then do the okay. So of course the strategy now is to open the strut towards the diagonal, open the strut towards the surf, and do finger insertion.
Thierry, I just want to understand very clearly the rationale for opening the struts is because these are large vessels, is that right?
Yeah, exactly. So of course, in terms of functional assessment, if we do FFR, it will be probably okay. But because the patient is young, is diabetic, we have to treat lesion distal to this strut, so we prefer to have that strut open. We prefer also that the strut are open because we know that now that there is cases where the struts unopened are colonized by neoendothelium, which create a post-stenosis at the outcome. And we know also that rheology is very important for the long term. Having a poor rheology in the side branch may promote atheroma in the side branch or in the main branch. So now Hakim is trying to take the distal strut. Yeah. Okay, you are I think.
So Jean, any views from the panel while we're watching the side branch wiring?
Any comment on the side branch wiring?
I think I'm very positively surprised about the results from the diagonal side because really.
Yeah, of course, we can do that also, but our philosophy is that when the side branch is big, we prefer to have side branch.
I think, okay, the diagonal has a very nice result.
This is classification message, huh?
But people are thinking, you do what we call turning weight. I always
Do you want to discuss this step of the procedure regarding the pot or regarding the crossing with the wire through the struts?
Yes, Hakim. I just a question. In a small branches like a diagonal branch, it's maybe one strut or maximum two struts covering. It makes a difference to go distal or proximal, and you can judge it angiographically. This is maybe very useful in large vessels, like the circumflex, to go in the distal struts or the proximal struts. It's very difficult to localize in this very small branch. I don't know if I'm right or not.
So you have to go this to reach the distal strut. you have to go to distal to the bifurcation and coming back very slowly, and then fall in when you did a very good pot. When you are coming back with your wire, you can really fall in the branch, crossing the strut. For this case, it was not really falling inside because I had to manipulate to cross the strut. But usually, when you have large vessels, it's really falling inside because with the pot, the strut is really open.
Yes. Okay.
It doesn't mean that you manipulated for few seconds or 1 minute that this is osteal embarrassment of the. It does not reflect a tight lesion. Do you agree with that?
Yeah, absolutely.
Okay.
But it's not reflecting the tight lesion. It's regarding the architecture of the stent regarding the osteum. So sometimes you have to work a little bit to cross.
Let's speak about the side branch wiring or rewiring. I know that Bernard is preparing this, but you have to discuss. Either we have, for myself, I'm just the Euro PCR club, Euro intervention club. I'm using a new wire, a third wire. The second, that either to use it distally, approximately only in DK crush. 3, that you can use the wire and the after pot, very important, and then maybe have reverse wiring or pull back in order to go into the side branch. If there's difficulty in crossing the side branch, I'm using the microcatheter opposite the side and then I'm trying to cross it. I'm not using that to put a balloon for the jailed wire. I'm not using this technique. I know this is a Japanese technique, but I need your opinion about the difficult cases like this in order to remove or to use the jailed wire in crossing.
Yes, usually we don't use, of course, the jailed wire to cross through the strut. But if you have an occluded diagonal branch or side branch without the possibility to cross through the struts, it's for salvage, for saving the branch. You can use this technique with the dilatation of going through the jail wire to open the side branch and then recross through the stent. That's only for saving the branch. It's not usually done. But I completely agree with you, Mohammed, with the third wire to cross distally. And if you want to be sure that, especially when you have a big side branch, if you want to be sure that you crossed another strut, a distal strut, you can do a graphy to see the image, and you will see a gap between the jail wire and the wire recrossed through the strut of the stent. That's a good tip to see if you are in the distal strut.
The point
if you want, we can move a little bit more.
Okay. Yeah, I mean to watch the guiding, because sometimes the jailed wire take your guiding in the stent and you can deform it. You have to watch it very well.
Now we can use two sides on both sides. We can maybe 25. Okay, so we do the teeth with the 225 in the side branch, the diagonal at the osteon, and the 3-0 in the LED, and we will take careful of post directing the distal part of the stent.
Have you an experience with the panel concerning the laser stent? I mean, the question from the eye about the stent, the laser stent with the large dilated proximal. We are I'm always afraid that there is just
there is no metal. And I think the risk of stenosis is really important. But I think we are waiting for several trials to confirm that. So we did some trials on bifurcation something like with this device. I think it is really nice. You have to know how to use this. You need to do postulation on this device, otherwise you might have this rate of problems. I think it's a nice device to have even more tapered circulation. Because this situation we can still handle with conventional step in a more difficult situation where you have to do PCI, then
For this particular level,
I wouldn't take it for this one also. I think for this one we are with conventional step.
okay.
Okay, we can open
Thierry, we are back with you.
Okay, so now we'll open the thread with the 225. It's a non-compliant, so we can go to the curve of 16. And we'll do the brief with the 3.0. Before that, we post dilate part of the cell. The stent and the LAD is perfectly apposed. We not do a lot of FPI because the realization of patient is not good. It is the side view showing the bifurcation between the MSC and diagonal, and this is the cranial array caudal. So I think a very nice result. Then so we give time to react.
Sorry, I have summarized a little bit the case, but we did, of course, the kissing with the circumflex. We did the kissing with the diagonal branch, and the result was quite good. So you will see.
We have 6 minutes left of the transmission. It looks like we've been making some excellent progress.
So let me show you only the result.
And then we realize that we should explain and show why we can do it without OCI, because looking at the angio, we are able to see that the distal line is involved in this lesion. We cannot avoid treating the left leg. So the purpose was just to show by OCI that you should treat the left leg. Of course, HFR was on board, and it was very important because if you have to treat the intermediate branch, you have to treat the third branch, it's a completely different story. So now we can show the final result, and then we go to back to react. This is the last, okay, so this is the LAO. You can see that now the percent of the LAD is perfectly apposed. We not do a lot of FPI because the realization of patient is not good. This is the side view showing the bifurcation between MSC and diagonal, and this is the cranial array caudal. So I think a very nice result. Then
So if you want to discuss this part of the live case, which was making kissing balloons, technique for the diagonal and the LAD, the bifurcation of the diagonal and the LAD, and the kissing balloon for the left main and the circumflex. Do you have any question or remark, Hamlet?
Okay, Hakim, we'll go. It's excellent. I think it's all clear and we all agree. But let me ask you as well as the panelists two situations in bifurcation and how to deal with it. If you have lost the diagonal completely, and it's a very important branch, you have lost it and you couldn't cross. What are the tips and tricks you're going to use in order to regain the diagonal, the side branch? Let's start by you first, then the panelist, or the panelist first. The panelist, okay, Dr. Sayed Ghizi.
Okay.
Dr. Sayed.
I think as Professor Hakim mentioned, that the first spot is very crucial in redirecting and recrossing the wire again. I want to hear if we are not able to cross with the wire used.
Yes,
Should
you
we?
lost the diagonal.
Yes.
The patient has chest pain.
Yes.
And what are your tools and what are you going to do? Which wire, which views, are you going to do anything?
I think if the wire used to recross, which used in the main artery are not acting, I think I have to shift to something like maybe something like cyan blue. Cyan blue sometimes is acting well in recrossing fastly the struts. I think this is the tool of one of my tools that I can use it. Also, as regard the point of kissing, do we have to do a high pressure inflation in the side branch before, in the ostium of the side branch before do kissing, or to do kissing immediately?
What about?
That's the question. No, you can do the kissing. You don't have to do high pressure inflation on the ostium of your side branch, especially if the side branch is not diseased. And for the point, very interesting point, when you have lost a branch, an important branch, you can recross. You can try to recross with other wires. You must do another pot, because sometimes when you make another pot with high pressure, you can have a small opening of the side branch, and then you can cross inside. So remake a pot, change the wire to recross. Sometimes with Gaia wire or other wires, you can recross the strut. And the last tip and tricks that you can use is using the jail wire to open the side branch with a very small balloon. Then if you get through the jail wire in the side branch, you will be able to open the side branch and then recross and make of course a final pot to impact the stent at the proximal part of the bifurcation. So usually with these strips you can find a solution.
Hakim.
Of course, you can also use angulated catheter to improve the support to cross with a wire and material like this.
Hakim, for your last point, which is recrossing upon the jailed wire, after pot with the 5, because I faced it several times, it's impossible to go with a balloon. Maybe before pot. But after pot, it's hell. I've tried it several times.
I don't say that it's easy, but you can recross with a very small balloon dedicated to CTO 1.0 or 1.25. You can recross. We did it I did it 2 times, and we did it. Thierry did it, and I'm sure Bernard and Thomas also. We are able to do that. Okay. After making a good pot.
Hakim, thank you very much for this illustration about tips and tricks, pot, repot, wiring, rewiring. But I have also something which you learned from an expert intervention like you and others in different life, that if you are ending with the bifurcation, this is very important, is to go with the guiding out and then remove wire by wire and balloon by balloon. Because sometimes when you finish and you are happy with what happened, and you move 2 wires, 2 balloon immediately, something will happen in the guiding with the left main. So this is, I think, my advice. I learned it because already I have some problem in the past with this kind of. I know Khaled is doing the same.
When I finish this procedure like that, I usually finishing my work by final put, because I usually expect that the guiding hit the proximal tip of the stent, So I usually terminate by final bolt. Yes.
Yes, I fully agree with Dr. Khalid. Yes, especially if I have an osteal stent. The second point is to prevent, to expect that your side branch will be closed. Osteal lesion, very bad angle. If you have more than the right angle, it's very difficult to go again to the side branch. So you have to fix the side branch first in this case. And the use of angulated, very stiffer wire is also useful. The angulated microcatheter also can be helpful in this case.
Okay, for the last comment, I'd like to add one experience that I had it twice. When losing a big diagonal, and I failed with all the maneuvers, and I was working radial. I used the second wire from, second guiding caster from the femoral approach, taking a good support with Amplatz 2, and then going by another wire, leaving the same, it's double guiding in the left main, and I succeeded.
I have an experience once losing big diagonal.
Yeah.
Almost was the same caliber of the LED, yeah. And I lost totally the diagonal. I use in such case I usually use a 5-cross microcatheter to help me to go to the ostium of the side branch, and like Hakim said, he tapered wire be helpful in some because that is not trackable. I used Conquest Pro 12.
Okay. Yes. So we will move to Dr. Bernard Chevalier, but I'd like to comment for the last one. Sometimes during such cases in the left main, you have longitudinal compression by the maneuvers. What are your tips and tricks to solve this problem?
Left hand control, that's very important. Yeah. You have to remove the guiding catheter when you remove your balloons or when you remove especially the jail wire. The left main control, that's my principal advice.
But what if it happens? How are you going to deal?
You have to deal with, so sometimes you must redo, of course, a part, and if it's not enough, you have to put another stent on the ostium.
Okay. So any further question?
And you will have more information with the talk of Bernard for the troubles regarding the side branch and recrossing.
Okay, so we'll move to Dr. Bernard Chevalier. He's now, we can access to him. Thank you very much, Hakim.
Thank you.
Very nice.